Respiratory syncytial virus is the most common cause of LRTI in children and infants and is the most important cause of morbidity and mortality in all age groups. It is a common cause of LRTI in children less than 1 year of age, especially bronchiolitis. Hospitalization rates are highest among infants less than 6 months of age. It is also a common cause of outpatient visits for children less than 24 months of age. It can cause various diseases in children, especially bronchiolitis and apnea. In a systematic review of cohort studies that included 5,575 infants hospitalized with RSV bronchiolitis, the incidence of apnea ranged from 1 to 24%. Among the extrapulmonary manifestations, it can also cause several cardiovascular, neurologic, liver injury, and inappropriate ADH secretions. In older children, it is also a common cause of upper and lower respiratory tract diseases. The patients at risk are infants younger than 6 months of age, particularly those who are born during the first half of the RSV season, infants and children with underlying lung disease such as chronic lung disease, that is bronchopulmonary dysplasia and cystic fibrosis, infants born before 35 weeks of gestation, infants and children with congenital heart diseases, HIV-exposed uninfected infants, patients with Down syndrome, immunocompromised patients, patients of any age group with persistent asthma, adults with cardiopulmonary disease, and residents at altitude of more than 2500 meters. In the northern hemisphere, the RSV season usually ranges from October or November to April or May, with a peak in January and February. In the southern hemisphere, wintertime epidemics occur from May to September, with a peak in May, June or July. Palivizumab is a specific monoclonal antibody for respiratory syncytial virus. It targets the fusion protein of RSV and inhibits its entry into the cell, thereby preventing infection. It was first approved for medical use in 1998. Indications for Palivizumab use in children are patients born prematurely at less than 29 weeks and less than 12 months at the start of RSV season, patients less than 12 months with chronic lung disease of prematurity, patients 12 to 24 months with ongoing CLD of prematurity necessitating medical therapy, certain patients less than 12 months with hemodynamically significant congenital heart diseases, patients less than 12 months with cyanotic heart defects and congenital airway anomalies or neuromuscular disorder that impairs the ability to clear airway secretions due to ineffective cough, patients less than 12 months with cystic fibrosis with clinically evident CLD or nutritional compromise, patients 12 to 24 months with cystic fibrosis with severe lung disease, patients less than 24 months who are profoundly immunocompromised during RSV season, and patients less than 24 months undergoing cardiac transplantation during RSV season. The dose in both pediatric and neonatal age group is 15 mg per kg intramuscular once monthly throughout the RSV season as described before. The dose has to be given 48 to 72 hours before discharge or promptly after discharge. During a typical RSV season, up to 5 monthly doses are recommended. Common side effects include skin rash and fever.